Here we are. We're going to do some low back, lower extremity work, but we're going to tie some other things together with that. So first, tell us your case history a little bit about what's bothering you.
I've had recent, so this is probably about a month and a half old, hip pain.
Okay, right. You're actually pointing to like the femur head and the acetabulum.
Both sides I injured.
Okay.
And my low back.
And what happened that you injured it?
Lifting too much.
Okay, just lifting, and so now the pain's there and it stays there, won't go away.
No, it comes and goes. Camping a couple weeks ago, I stepped on a rock with real thin shoes, and it's bruised, and it's still bruised. It really hurts in the morning, doesn't hurt much for the rest of the time. But when I first get up, put weight on it, or at the end of the day when I'm tired. If I percuss it, it goes away for about an hour.
Which tells us that you're treating the localized pain, but it's really coming from somewhere else. That's what that says. All right. So he'd be a good one to do the whole protocol too, to see what is it you would like us to know about you. So let's just start there. So just go ahead and stand right there for a bit. And let's go through the protocol. Hold tight. Don't let me go down. Let's see if you're testable. You are. Let's see if you're switched. He's not. Electricity. We'll see if EMS are bothering him. Hold. They're not? Are you been using the magnet at all?
Yeah.
Okay, so he's using that. You have it on now?
Yep.
Okay, so it's working. Sometimes, like I said, it'll take more than one. Next thing we want to check here is adrenals. Stretch. Don't let me go down. Okay, so you've been using some DSF or no?
No.
Okay, hasn't been using any DSF, so he's good to that point, but now we know he has some stress. He's a school teacher working with students. They actually teach chiropractic students, and he's getting ready to go into practice as well, or expand. You on practice some now, or just barely going back in?
I signed a lease offer on Wednesday.
That'd be enough to make anybody's adrenals a little stressed out, okay? Do them both at one time. Now, these guys are really a blessing to our profession, but it's hard on them. So the next thing we're going to go to is liver. Okay, liver is showing up as well. Well, it's no wonder we're having some problems here. So there's liver and gallbladder, cystic duct, heart. Good, heart didn't show. I was glad for that. You hate to have a heartless school teacher, right? Okay. Homocysteine shows up, though. That's a problem. Okay, so homocysteine shows up. So we're coming over here. Spleen, pancreas, stomach. Whoops, leaky gut. So he's got quite a few things going on here. Okay. Drop down to bladder. Male organ, fine. Prostate area. Pituitary to thyroid does go weak, and this really got weak. Now he's actually sweating up here. I'm doing most of the work, but I feel
I took a walk at lunch.
Okay.
Does that make a difference?
It could. You might be still there hot, but it feels like just the fact of being up here and we're testing it seems to be more. This leaky gut?
Oh, no.
What was that?
GHR.
Oh, GHR. Yeah, I'm there. I got sidetracked just by how much he's perspiring now, wondering if the sympathetic parasympathetic system isn't out of control here a little bit. It might just be the fact he's walking now, he's still heating up. Okay, GHR really showed there loud and clear. So it helps you see how you have a back office person that leads you. It makes you go a lot faster. Then the next thing we want to know is there any infection processes? Yeast, virus, staph, strep, parasites. So this is unusual, but we found 3 sets of parasites today when we've been checking. I mean, there's a lot of them out there, but usually like strep or staph or something's on top. But a lot of you guys have already been on some of the nutrition, and it's starting to bring it up. So let's check total para. That definitely helps him. We check what metal showed up. Lead, what? Lead and F complex showed up. So we'll check the lead to make sure everybody's aware of it. It is. And then it needs the F complex to help neutralize it. So we know what's going on here. We have a fatty acid problem. We have a lead contamination. We have leaky gut, liver stress, adrenals are under stress. I mean, there's all kinds of stuff. No wonder he's not holding his adjustment. You remember, without the DSF, just stepping down off the platform would make him go weak. So it's important that we have that balance. His major problem is pain here, but what is the real issue here? Dr. Prisby, let's have you come up, and before we actually fix his lower extremities, you know some of the tests that you check are extensors and stuff. Dr. Prisby has a way that he helps evaluate our patients during the examination to see if there can be an upper extremity lesion showing what's going on. So I'll turn you over to Dr. Prisby just a minute. Remember, P stands for pain. So Very good. We'll get these out of our way.
I noticed nobody laughed on that. You haven't been here in the office with me yet. Go ahead and sit down. So y'all know when you go through and do your basic orthopedic neuromuscular, and you do your motor exam, basically you go through and you check the deltoids. Go ahead and put your arms up like this. Nice and strong. Have you come down here, we'll check the biceps. Hold tight. The wrist extensors. Now those are testing strong. Wrist flexors. Nice and strong on all of those. Okay, so everybody knows how to do all those. But you know, sometimes I find people, they have disc problems. We check them, if we check them this way, hold tight, and we do a compression on his head, and something shows up. Now, why didn't we find something there? We know something's there via the kinesiology test, muscle test. Why aren't we finding it? Doc, have you come help me?
Sure.
You can have the patient compress the head to do this, or you can have an assistant come in and just compression there. Now, hold out like that. He's going a little bit weak on this side. You feel that? Oh yeah. Okay. Okay. Go through. We can check these. Hold tight. Wrist extensors. Extensors. There you go. Just like you're riding a motorcycle. And back like that. Back. Bring it back. Okay. And that one's going a little weak there. That was nice and strong. Now flexors, wrist flexors. It's a little bit weaker on that side, on both sides. So that's a different way you can go through and correlate. Actually, you know, this is neutral foraminal compression. Everybody knows that orthopedic test is just combining the motor test with the neutral foraminal compression. Now I went to a seminar by Dan Murphy. Everybody knows who Dan Murphy is. He's talking about how he had a lawyer actually come into his class one day at Life West, and he knew the guy was a lawyer. He said he smelled like a lawyer. I don't know how he smelled that. I haven't smelled enough lawyers. But the lawyer had this case, and he felt that the patient was genuine, and the patient had pain on down his left arm, but the MRI showed a disc lesion on the right side. And so they said the symptom everybody was saying, and the opposition of the lawyers, the defendant, I guess, for the insurance company, the lawyer said it doesn't correlate. The symptomatology does not correlate with the objective findings, so he must be malingering. But Dan says, no, perfectly correlated. When the nerve root comes in, it decussates. It attaches right there. I'm not sure where the parts are called exactly, Dr. Amy. You can help me out on that. But it decussates, crosses over, and the disc lesion happened to be right at the front part of the disc where the ascending fibers go up to the brain. So sometimes you can have pain in the left side, leg either side, arm either side, from the opposite side, disc lesions. So we go through and we can check things this way and then check them on the other side. You know, I found that we can go here, hold tight. Sometimes you don't have somebody to help you do this, but I'll just show them this way real quick, Doc. Once you activate it like that, it kind of brings it up on display, and you can just touch along the, okay, we found it right there at 5 on the left side. So we could go in there, we could fix that. But at the same time, there might be something on the opposite side that's also brought up on display that might be feeding back across to the left side. There's one at 4 right there. So you go in there and you'd fix it at the same time. With these ones on the opposite side, sometimes they don't actually show up, though, at all when you're doing the compression test.
Okay, just hold right there for a minute. Lie on your back, if you would, please. Say it again.
The opposite side is called a long track strength.
A long track, T-R-A-C-T.
Long track on the other side.
The long track sign.
You got to look where it's at the spinal cord itself to find the opposite decussating travel right at that extra.
Okay. Let's just ask his body a few things here. Turn the foot out, hold up, don't let me go down and out. Okay, soleus is intact there. Take it out here, turn the toes in. Hold tight, don't let me go down and in. But we do have a weak TFL on that side. Let's check the quadriceps. Hold tight, don't let me come down. Okay, hold tight here. All right, so we have a weakness here. So we have several weaknesses that we can see on the right side. Which side was the pain on? Right side. Okay, let's remember that. Let's check the left. Hold, don't let me come out. Don't let me pull down the quad. Okay, take it out. Check TFL. So everything is intact on this side. All the pain's on the right side where we found the weakness. All right, check range of motion, see where that is. Got to remember that. All right, go ahead and fix the cervical disc then. And we'll see if that makes a difference on these lower muscles here. Since that's what we're talking about, that's where the pain is.
So I'm just going to self-test. I know generally where it is. I'm just going to self-test to find the exact vector. I come in here, make the contact.
Did you understand how he did that? If you're all by yourself, you'd just take your knee against his head and you'd push it like this and then test him. But he had just checked him up there, and now he knew. Now he just self-tested to get the exact spot. Slides in from the front here. Right. And he's adjusting A to P like this.
Okay, bring your hand up. Hold tight. Okay, let's just go ahead and check this little conjunction of neurofemoral compression and motor test at the same time. Okay, hold tight. Okay. And you see the change in that motor strength right there. He's compressing the head the same way. So we could go ahead and set him up and check it in gravity as well, coordinating the gravity test and everything as well, but let's see what happened there.
Turn, hold tight, don't let it come in. Hold.
Piriformis was weak on that one. The TFL was weak when he checked it before.
So all
fine.
all areas are strong, and we never touch the low back. As you know, if you don't fix the cervicals, then you're not going to fix any part of the body. So maybe upper cervical isn't all that far-fetched, but this lets you know exactly where it's at, what it corrected in the long term. I mean, now the strength is just, it's that rebound. That's what you want to see when you test the muscle. You want to see it rebound at you, just really good like that. Hold tight again there, check that quad. It's just really strong. Hold tight. So would we stop there? No, we go ahead. There could be a low back problem as well. So I could check here. I'm just self-testing and asking, is there a category there? No. Is there there? Yes. So I'm getting category 2 on the right. If you couldn't self-test, how could you do it? Well, we already know we have a strong muscle. All you'd have to do is put his right hand under his right PSIS, his left hand under his ischium there, and check one of these other muscles that we already knew to be strong. Turn the toes in, please. We're going to isolate a muscle. Don't let me come down and in. Okay? And look how weak he is. Hold tight. So even though we fixed the neck, it didn't fix the low back, even though it strengthened the muscles. So now he put his hand here and here. That's where we put the blocks. Wherever the hands were is where the blocks go. So we slide that block here like the regular blocking technique. And you'll find all those are in your advanced notes, exactly how to do those if you're not sure. But so we're blocking him up as if it's a category 2. Then I'm just, while he's there, he actually says he has femoral head pain. So let's go ahead and percuss him. Now, since we found that there was an upper cervical problem, let's check if there's a cranial problem too. Breath in through the nose. Out. Yes, he has the inspiration assist. Breathe in through your mouth. Hold tight. Don't let me go down. He has the glabellar fault. So we have 2 cranial lesions. So let's just go ahead and turn the laser on. Let's use the frequency setting of 60 because it's for the brain. Let's do it like 1, 2, 3 minutes. And we'll shine it right along the corpus callosum, a great white commissure, and it'll integrate the right and left brain to be working harmoniously. At the same time, I'm going to be taking the percussor now, and I'm going to realign. Okay. Yeah, we really should do that too. Some of you are not aware that we have developed a way for checking and fixing the gait at the same time. All you have to do is check a muscle and make sure they're strong. Go ahead and cross one leg over the other one. Hold there and don't let me go away. And that makes him weaker. Cross it the other way. He's strong there, but go back the other way, where actually his right leg's over his left, and you don't know which way it is. You just ask. So that got weak when he did that. What does that mean? He is stuck into a gait pattern, as if his body's always taking a step with the right leg forward. So if the right leg is forward, then the left hand should be here, and this like that. And you might even want to make sure if there's an emotional problem, you can have him hold up on the emotional centers at the same time. Understand what I mean by a gait pattern? Every time you take a left foot forward, the right hand comes. So when the right leg goes forward, the left hand goes forward. But when you cross them over like that, it's as if the body is stuck into a gait pattern. So we leave him in the pattern while we make the correction. We're lasering the cranium up here. If it's just you by yourself, you just stick it in there and lay it where it's going there. So we're unwinding with gait. We're correcting the category 2. Now I take my percussor, and I'm going to unwind any fascial restrictions. So I'm going to strike right on this right side on the proximal fibula. My listening hand goes here. I put pressure into there. I can feel it building up. There it goes. I just felt it release. It's that fast. Come back here to the femur. Okay, so I come on the femur. I'm on the distal femur. My listening hand is on the inside. There it goes. It just released here. I might want to come down too on the distal fibula. I'm holding here, holding it back. I want to take that twist anywhere out of that femur because he's been treating the foot specifically. That's what he injured. But if this fascia restriction is all the way up, then we're never going to get it to hold. So now I'm going to come right here, and I'm going to come right on that right femur. I'm actually on the greater trochanter, holding back with my left hand. So I'm releasing that greater trochanter. What that will do is slide the femoral head right in the acetabulum, take the stress off of it all over. So I know you can't see real clear from where we are, but it would look like this on the other side. Proximal fibula head, take the torque out of this left knee. We could do femur. It doesn't matter whether you go up to the distal femur and then down to the fibula at the distal end or vice versa. It's the same. Now when you fix the right acetabulum, you don't have to go to the left. Fulford found that it released all the way across. But also here it's really good to check the symphysis. Almost always the symphysis will be involved when we get in a category 2 under this situation. So you go right over the symphysis pubis. You can monitor on the anterior superior area or across the pelvis, and you'll just feel that relax. This will help bladder problems, vaginal problems in some areas of ladies. It definitely helps prostate problems, sometimes testicular pain in men. And a lot of times you'll get testicular pain because of the upper cervical involvement, C1, 2, 3. But it'll also fire and cause weaknesses, as you know, in the gluteus maximus, minimus, and medius muscles. So you want to free it up here and at this level. Okay? So at this stage of the game, he's been doing good there. How will I know when I'm through? I'll come down here and check him. I can do a specific test, or I can just do a group test. Okay, I'm just doing a group test here. He's into yin. He's into yin because he no longer needs the blocks. We've corrected the category 2 in the gait. As soon as I take him off there, he'll go back into strength again. We've corrected gait, we've corrected pelvis, we've corrected extremity, we've fixed the femoral head and the acetabulum. I just expect it can get completely better. Now it could be, though, he's actually damaged the foot as well. Now he told me he'd already done some percussion himself, but maybe he hasn't got it all the way. In the office, this is exactly how Don and I work, or the other docs too. We have chairs on swivels. I'd come right in here, I'm doing the plantar fascia. I could do the calcaneus. I can come up to the Achilles tendon. We can go ahead and check all the major bones in the foot. You do the navicular and the cuboid. If you're doing the whole foot procedure, and it's just about this long. I'm getting complete releases at every level. I can even come to the talus here, make sure that the mortar joint is intact. All right. Once I have that done, I may want to do some mechanical correction there. So I could take the foot here, adjust it any way you would adjust it here. I may want to sit on the foot like this, make sure that calcaneus is not strung backwards. Okay, pull it right back into place. Sometimes you hear it go clunk. We've only worked on the right side basically, but I expect to see improved motion everywhere. We have some tight adductors here, so it'd be nice to percuss or laser that. But we've corrected him out. Flip over on your stomach.
Done. At the same time, we probably want to be checking it because of the referral pattern of the visceral somatic. Pain can be referred from the large intestine into the hips and TFLs as well. So that'd be something you could do while he's face up as well.
Another thing we can check is see if he now, can you have a category 2 and then go into a 1 or a 3? I check him right now. It says, yes, he's a category 1 as well. So I'd want to block that to fix it. I could do a leg check here and see what he has. Leg-wise, from what we've done already, he's pretty level. I didn't check it beforehand. You could touch here, and if he goes weak, then you know he does have a category 1. Then you can put the hands up and down, and wherever they go weak, that's where the category is. In this case, I just ask, and it's like PI on a right. So we're going to block it, like here. You always want to see if it goes up into the shoulder, too, because it can be where you might have to lift the shoulder up like this. You also could check to see if he is into a gait pattern here. Hold tight to let me go away. Okay, you can just, it's not a very good one to do it with because you have to cross over like that. Hold tight and let me go away. I was just trying to get where you could see. So that's the way he's into a gait pattern. And the easier way is to take a muscle like this down below it. Hold tight, don't let him go away, please. Put it down and forward. That makes him weak. Cross him the other way. Hold tight, don't let him go away. Strong as a rock. Go the other way. A lot of cases that you're not getting cleared out, recurring back pays, we have found that this is the key. We go ahead and we do the gait pattern at the same time. So this is as if the left leg is taking a forward step, so we know the right hand should be forward. We'll pull this left one back up along there. So in other words, we found out that it's his left leg stepping forward, so we leave his right hand up while he's crossed in this position, then we let this other hand come down to the side. So he's actually exaggerating that gait pattern. Now that he's there, we can do anything else we need to. We could check for a Logan basic, which he has on the right side. He needs a Logan basic on the right. We could check for iliolumbar ligaments, a fixation here. So I'm self-testing, and I just ask. He has a fifth lumbar on the left. He has a fourth lumbar on the right. They're fixated. Well, if you don't know how to self-test, you could just say, I know that pattern happens a lot. According to the Gnostic practitioners, the atlas subluxate to the right 80% of the time. According to the work that Cottam did, the fifth lumbar goes left against the fourth lumbar that goes to the right. Then the 10th thoracic goes the opposite direction, 6th thoracic goes the opposite way, atlas goes the opposite. There's a whole research paper that Dr. Goodhart did on that. But simple to remember if you don't have all that stats. Hold tight here and don't let me go down. Always check and hold S1 from the right and fourth lumbar from the right, and just push that fifth lumbar from left to right. And you will find a vast majority of people with chronic low back or leg pain have that fifth lumbar to the left. So it's real simple to correct. If you have drop pieces, you could use that, or you can just take the round ball like this. On the adjuster, hold S1 and 4L. You come back and you'll just tap it right in and re-challenge it. I mean, strong as a rock. Also, you can then take the percussor and do the iliolumbar ligament. Remember how the ilium and the lumbar spine are tied together with that iliolumbar ligament? A lot of times it goes into spasm, causes the problem. So I come right in on top of that iliolumbar ligament. I feel with my listening hand over here, I'm going to unwind that whole pelvis. Come over to this side, going to unwind the whole pelvis. I can do the sacrum, free it up right here. What if we found the attachments to the hamstrings were locked up? We come right down to the attachment here. So we can release the third lumbar from this position while they're on the blocks. We know third lumbar and third cervical are the two most powerful points that we can percuss in the spine. Most of the time you do it when they're side lying, but you have him on the block so you can get a very dynamic clearing while he's there. That's how long it took me to clear that. Yeah, it cleared that fast. But in that particular case, that's how fast it cleared because I already had him prepared. I took care of the fixation area, had him on the blocks. I've already cleared him from a 2. Sometimes it won't be that fast, but it cleared completely in that length of time. For you, when you're learning, it'll be longer because you won't be able to direct that force exactly. Remember what Fulford says, your intention is more important than your technique. If you're intending pure treatment, love, harmony, correction, but if your mind's on your golf game, you're in trouble. I mean, you just don't project as much energy. So how do we know when we're done? Hold tight, don't let me go down and forward. Okay? We're going to go into yin. Now, it wasn't a clean sweep, so I'm guessing there's still a little bit of ischial problems there, so I'm going to come into that Logan basic type technique. Yeah, what Beardall is the one that coined that term. When a person went weak all over, every muscle turned weak, that means that you had such a major correction, the whole nervous system goes weak all over. Then when you take them off the blocks or whatever you're doing, you quit doing it, their body will go back into strength. The only reason I said down on the lower trapezius muscles, because that's the way you check it, is from inferior to superior, posterior to anterior. That's the way you check the lower trap muscle. Okay? So let that relax. So we're here.
You just also spin that? That's what I do.
Yeah, you could do that, but when you have the feel, I like to feel it and just really fine-tune it from there. Okay. Hold it. But yeah, if you're half-ended, then just use the arthro stem. No, just kidding. What he's saying is you could just take the round ball, or even better, and you'd use the small tip, and you could go, you'll just feel that right in that notch. You just come right into it, like that. But you want to be careful because with the adjuster here, you're actually giving a little bit of a force, and if you were off direction, then you might set up a compensation. Or if you learn to feel that, it's so fast, I don't even take time to go get it. You just go into your tight, and you can just feel the body relax. You say, where did a Palmer boy learn about Logan Basic? From my Logan associate. He was very good at it. Okay, so what we have now is a fixed problem. I don't think he has it anymore. I think whatever we started with is corrected. Muscles will be better, range of motion will be better. I really expect the pain to clear up and not come back because I've corrected the pelvis, I've corrected the fascia, I've corrected the fifth lumbar area. Turn over on your back. The only other thing that I would worry about is what if he had a facet problem? If the lumbar spine itself had slipped and we actually had an imbrication or a facet. So I can ask that question very quickly. Okay, leg out, turn your toes in, hold, and let me come down and in. I'm going to traction it and see what happens. Whoa, he did get weak. It's a good thing I checked that. Hold out tight. And you say, well, you just stretched the muscle. I thought that was an adrenal problem. I've already corrected the adrenal problem. When I check him here and stretch other muscles, I don't get weak at all anymore. I'm only getting weak down there because the facets. You want to block him and do that, Doc? Mm-hmm. So we slide it in here, up about between third lumbar and fourth, and then Doc's going to go ahead and pull it up, just traction. So you always rotate the toe in a little bit there to take the stress off the knee. You just use a sharp, quick thrust. Good?
We have the other side too.
Please. Both of them show, so we're going to do both sides. He bends the knee here to just relax the lumbar spine. You don't have to do that. It just gives you a little added protection. Okay. A lot of times that'll help correct the knee as well. So did you see how that was? That's why people, it's amazing as I talk to doctors on the phone, they say, well, can I learn to do this stuff without kinesiology? It just isn't consistent. I just don't understand that. It's like reflex testing is consistent, range of motion is consistent, shooting a gun is consistent. You have to learn to point, aim, and shoot. You don't point, shoot, and then aim. Okay? And that's what happens with people. They just slop it and expect it to work. But it's a very easy type testing. Hold tight again now. We just took care of the imbrication or facet syndrome. And that's one reason that would not stay out of pain as long as you left that facet irritation in there. You just remember, there's a lot of pain fibers in the facets. Okay, questions on anything?
I did this to a lady the other day, and it made it worse. Everything checked normal, I just gave her a nice little crack. She was an elderly lady. I thought I did it real easy on her, but she said it made it worse. So I followed up with her a few days later, and she wouldn't talk to me.
You have to really be careful with these type of things, particularly on elderly people. Now, did you block it underneath? Okay, you want to block it here, and it takes very little pressure. But make sure, I've already released the fascia. Okay, you could hurt somebody if you use too much force, but boy, if you just, it's a very gentle technique, opens up through there. I mean, it'll just get you out of a lot of troubles. You might have done it too hard. You might not have freed up the iliolumbar ligament. If the iliolumbar ligament is jammed, sometimes it can cause irritation. It could be. It could have been an emotional connection if you don't clear it all out at one time. Okay, boss, I expect that to be better. And here's your shoes. Okay, any questions about anything from you or anybody else about that?
I didn't tell you this, but I have a grade 2 spondy.
Okay, he has a grade 2 spondy. That also can cause problems there too.
That's probably why the facets are showing up.
Right, so you have to really be careful. It'd be nice to know we wouldn't want to be doing any PA thrusts on a grade 2 spondy, that's for sure. Oh, okay. Yes, doctor.
How will we determine if we need to percuss the other aspects of the pelvis?
Okay, how would you know if you wanted to percuss different aspects of the pelvis? You would just go ahead and do muscle testing if it therapy localizes. What I do is I self-test. I just ask, does it need here, need here? That's the way I do it. If, before I learned to self-test, I would just put my hands on people and I would feel the flexion extension, which we're going to practice this weekend, and you feel it right there and it's dragging you to that area, it needs it. When you put your hands on somebody, if you tie in the cerebrospinal fluid flow, you will just feel where the restriction is and it'll pull you, whether it's a lung or it'll pull you down if it's into a kidney, and you'll learn to feel that. The more sensitive you get, the more you're directed. Yes, doctor?
Yeah, okay. Thanks. Spinal, like you have to do the percussion at all three, or skip that section, or
The spinal is where, Doc? 5L. Then I wouldn't be afraid of percussing really over it, but most of the time I'm going to go above and below it. I'm going to make sure the sacrum is free. I'm going to make sure above it's free. And then sometimes I'll actually take and have them bend their knees back into the chest and then use the drop pieces of the table and drop it down in, or percuss there and release it. But you don't really stir up much trouble with this light work. When you start going crunching, then you can wind up with troubles.
you have a disc protocol for lumbar region?
Say it again.
A disc protocol
for the lumbar region.
Well, yeah, does anybody think they have a lumbar disc? We'll just take them through that. Why don't you come on up. Doc, Dr. Amy, you want to show a lumbar disc protocol?
Lumbar disc?
Yep. Yeah, what you would do for that. Yeah, I basically take people through exactly the same thing, and then I put them either on a Cox or a Leander table after I free all that up, and then I stretch it in there, and then we laser it. And we have I haven't had to send anybody for surgery in many years now doing that, many years.
I've got it now too. Got paresthesia.
Okay. All right, tell him what's happening.
Basically, we treat these pretty much the same. We're going to do a protocol, and we'll just go through this. We're just going to find out a little bit, tell us a little bit what's happening with what's been going on.
Well, I had a fracture and a disc injury when I was in my early 20s, so I've had low back problems off and on since then. The MRI showed just a mild bulge, and that was several years ago. And usually I get left sciatica, but for about the last 2 months, I've been having a lot of right femur pain and paresthesia running down about to my ankle, and it's also running down the back of my right arm, too. And I don't know, I just can't get rid of it.
Okay, so probably Dr. Prisby is what you guys were doing with the thing. You might want to check her on this one as well. Why don't we just come in? Why don't you just check her for the neck because she's shaking both, and then we'll go through it. So why don't you have it come out of here, and we'll come on onto your back. Is that what you like? Come onto your back? Okay.
Okay. Just check your muscles to start with.
So we're going to go through this real quick because she's saying she has both. She has neck and things, and it's transferred from the left to the right. How would that happen? It'd have to be a central disc, right? Central disc to affect both sides, right? And those are pretty rare. I got a pretty nice little one, L4, L5, but you don't find them quite as often.
I'm checking all the way down to T1. Okay, so you do some.
Yep, do the compression. So she goes a little bit on the left.
Yep. Okay, here.
Wrist extensors, you can feel those just go. As he went wrist extension, I got the hand, I can feel it.
Okay.
They're just gone.
Flexors as well.
You can feel. So now you're getting to where the level is, though, too. You're thinking in your head, well, where's the level when he's going through that? Well, when he said wrist extensors and she brought it up there, you could feel just the energy just leave out of her body.
Out. Fingers out.
Okay?
Yeah, so
Let's
3 or 4 different ones showed up there.
Okay. Why don't you have her on her back? Let's fix those. Give me a test for you, and you can do it. Yeah. So this is what we go back to before when we were talking about you have to fix the neck. There's more receptors in the neck and even the low back, and that's going to affect everything else, from a knee pain to Achilles to a plantar fasciitis to anything like that. This is really where you want to check.
She has a cross at about 4.
So she has a cross at 4.
Okay, other hand. Maybe once again, the disc on the opposite side, along the long track once again, like Dr. Randy said, affecting the left side, affecting the right side.
He's saying when he does the muscle test, right, she's having pain on one side, but the disc is showing up on the other side. And he's saying the sensory afferentation, so if I have sensory coming from here, it's going to go to my left brain. As it comes up the cord, pain comes up. Goes into the cord, goes up 2 to 3 levels, and then crosses over, and then travels back on up, okay? So that's what he's saying. Pain on the things. Predominantly, they say you're going to have the disc on the same side as the deficit or the imbalance, paresthesia, whatever it might be. It sure can be, in pain. Not so much usually in motor, but usually in pain. Yeah, you get out any anatomy book and you can take a look right in the spinal cord and you'll see where those fibers are.
These are the sensory fibers.
No, well, they're central, but they're a little bit more lateral here as it comes and decussates over. We get on a neuro book and you can see it right in the spinal cord. Okay, so we could have checked a bunch of other things, but we don't have to from that. We know that she's going to be better. So let's just see where she's at. Let's just sort of take a straight leg, let it relax, let it relax, let it relax. Good. Actually, she's pretty flexible, isn't she? She's get a little bit right here. So I'm just going to bring it down, and you tell me if this gives you any pain. Is that giving you any pain? Yeah. A little bit of pain. Where is it? In the calf, or is it somewhere radiating?
Calf.
It's just calf. Just calf pain. Relax, relax. Thanks. That's pretty good as well. We're going to come here. A little bit of calf pain, a little bit of calf pain. So I'm going to have her go face down for me. And we can go through, we can muscle test everything. We could muscle test for strength and the other things. We can check flexors and that. I'm just checking range of motion, and then we're just going to go to work here. So I want to, don't, just let it relax. Piriformis is pretty good, pretty good. I feel it lock up. I can feel it locking up in the adductor to the pubic bone. Adductor to the pubic, not so much in the piriformis itself. But this is really the one she's getting more. So this is really where we're looking at. Piriformis and sciatic. She's saying she's having low back. We're not seeing too much in that. So we're just narrowing things out. So what I want to do is I'm still going to unwind this a little bit right now. So what I'm going to do is I'm going to percuss. Maybe you could come in and you could laser if you wouldn't mind. So I want to open up especially this left side here where I feel it, where I feel the restriction from the adductors into the pubic, because that can give you knee problems as well. And then we're going to go over, we're going to flip her over, we'll do TFL, and we'll do hamstrings and calf, okay? So what I do is I bend the knee, and I hold it here. He's going to come right through here, and we're actually going to do the adductors instead of the piriformis. Usually in a sciatic or piriformis syndrome, I would go right into the piriformis, okay? So everyone with me? I am going to come put the percussor right on the piriformis, the sacrum. I'm going to turn it down just a little bit. I think it's a little higher than I want to be. And then Dr. Prisby is going to put the laser in. Now we could be checking, is it structural, is it chemical, is it emotional, is it visceral? I think probably a little bit more visceral here on this one. So as you lock it in, see, remember where she was? I mean, it's just really that fast, and she's great because she responds really quick. She responds really quick. Yes?
Are you testing for weakness or flexibility?
Right now, we're checking just flexibility. Okay, we're just checking flexibility. We could have checked all the strength, but we've seen that before. I'm just showing you the fix, okay? We'll show you the fix, okay?
So when he's doing this up here, he's just going right till he hits the wall, lasering and percussing till the wall dissolves.
Okay. Now, I'm not even going to address this low back yet, because if she has restrictions from other things, tying that down. So let's say she had a tight iliolumbar. She had something compressing on that. Then that's where we're going to work up. But I'm going to unwind the body first, and then I'm going to come in last, because I'm going to get longer, greater effects. I'm going to have you come onto your stomach for me. I mean, come up with your back. I'm sorry, you're already on your stomach? So here we go. This is what I find with people with really, really hot low backs. This is like one, they just think you're a miracle worker. What I have them do is I get the patient to be involved now. In fact, I'm going to do the other side so you can see it, okay? So I'm going to bend the knee, and I want to see where her motion is. Okay, she's getting pretty restricted there. I want you to come on in, and what you're going to do, just like a hurdler stretch, I'm going to have you laser the TFL. So this is for the TFL, okay? Everyone with me? I'm going to do the TFL. So I've already done the piriformis. I'm going to do the TFL.
Just regular frequency?
Yeah, 9. 9 is what we're going to do for the myofascial, and I'll try to come down low. So I'm not even going to percuss yet. So what I want you to do is I'm going to have the patient engage. I want you to bring this up. Hold it, hold it, hold it, hold it, hold it, hold it. And then when I feel it's enough that we're not getting any more, I'm going to have her relax. We're going to build up energy through using the laser. And you can do the same thing percussing, okay? And I'm going to do that in just a second. So let's have you engage again. Boy, this time it really starts to go. Really starts to go, and I can feel it's really deep. It's really rolling there. Then I have her relax. Raising up a little bit. Okay. Why don't you try to just put that down, or you set that down? You can flip it on your belt. Okay, so here we go. One more time. It's pretty crazy, huh? So that's what I'm going to show you now. So now you can come down, you can get percuss. So I'm going to do it from this side, okay? So you guys, I'll block you there. So we're going to have the same thing. We're going to bring her leg up. She's going to hold it. Okay, now I'm just doing the same thing on the opposite side. We're going to laser percussion. She's going to engage on her own, okay? And then I'm going to take her across the midline so you guys can see, okay? So I want you to engage. And I'm helping her out here, and I'm just feeling where it's restricted. And then relax. I feel a little bit more in the glutes. Bring it up, bring it up, bring it up, bring it up, bring it up. Hold, relax. One more time. There we go. There we go. Okay, now it's going to be a little bit different. I want you to bring it up, and then I'm going to bring it across. So we're going to elongate the TFL here this way, go across the midline. And this is where I feel she's more restricted on this one.
Until we get a laser, we can do it.
Just like that, yeah, just the same thing. We're doing the same thing there. And that's really unwinding here. Ooh. Yeah, she's good. That's it. Okay.
Remember, the fascia records and remembers all the
let's do
trauma that's ever
hamstrings.
been done to it. Chemical,
hamstrings.
emotional, physical. Until you go in there and
Right behind
release
you. Right
that
here.
fascia, it
Right here.
continues to
Right here.
resubluxate it.
We're going to run wider. So now you're going to laser. We're going to just do a little strain, counter strain. Let's just see where we are in comparison to where we were. We're already further from where we started, right? Just did 2. We just did the piriform stat. Come in laser. So once you do this, you take the muscle out of spasm, then you come in, you block them, you come back and you adjust them. That adjustment is so dynamic. It's unbelievable, the afferentation you get. You do a little strain, counter strain. I want you to slowly push into my hand, keep pushing, keep pushing, keep pushing, keep pushing, and relax. And she's really flexible, which is really cool because it's very dramatic. So that's a lot easier than digging in there, I'll tell you. Digging into your hands and the others. Okay, I want you to slowly push into my hand, keep pushing, keep pushing, keep pushing, keep pushing. Now she has some rotation. I want to take that out too at the same time. So I'm going to take out the rotation. I want you to do it one more time. Engage, slowly push into my hand, slowly push into my hand, push into my hand, push into my hands, and relax. I don't know how you can do it any faster, any easier, any better. So, do you think you've taken a little bit of pressure off the disc, off the low back? Okay, let's do adductors real quick. Adductors, you can do the same thing. If you had a percussion, you can just come in and percuss the adductors. She had some pretty good restriction on this side compared to the other side. This is the most important one for the lymphatics and the chronic knee pain you can never get rid of. This is the home runner. This is just, you're just swinging for the fences on this. Lymphatics, really people with heavy duty lymphatics, this really pumps it. Come right through the adductors. Right through the, right through there. In fact, I'll do that. Try not to find you too loose. So you can come right through the adductors, and when you engage the percussor, you're just at a deeper level, and it's going to unwind twice as fast. There it goes. Got a little bit moving it in the knee. That's what I'm saying. You can do it either way. You can do one.
Would it not be effective because you did half muscle one day and half the next?
Well, if you're going to do it the next day, yeah, you ran out of time. That's all you're going to do, though. But then the most important after you do this, because you've changed their whole memory and stuff like that, these muscles haven't participated through those ranges. I have them get out and I have them do cross calls and walk right away. Because you have to reintegrate this stuff. You have to reintegrate it, basically, is really where you need to be. You get back there and reintegrate it. So now you can go back and you can block them, or you drop table them, or just adjust them. Whatever you do, you've taken out the muscle out of spasm, so when you go to do the adjustment, boom, it just really locks right in. You really can potentiate more receptors.
Let's say you did those hamstrings last week, and Dara pulled you out there and say, something wrong here, and you got to go on
You can
another
bring it up. You have to go what?
And you're going on to another patient.
Uh-huh.
Some problem came out there.
Right.
So she's had an hour, she's left. All you could do that day was you got to her hamstring. She comes back the next week, you got to do the hamstrings over.
Well, if her hamstrings are as big as thing, remember those are flexor muscles, right? And she has a plantar fasciitis or she has a heel spur on that side, yes, I'm going to do the hamstrings again. It may only take me 60 seconds, though, because I've already done it one time, so every time you do it, it's going to be that much easier, right? So it's only going to take you a second to do it, and then I'm going to get segmentally where she needs to go. Okay? How do you feel?
Better.
Yeah, so you feel better. I mean, sometimes you hit people that they're one-shotters, one time, but people that are really chronically on the low back or hot discs that you just, no one can touch, you do the stretch and you bring it over, you percuss them, and that, I mean, sometimes they just think you're the miracle worker because you're taking that pressure off the disc.
Did we start with her neck out this after lunch?
We did because she had disc. Remember we did the time before? We did the time before we were saying, hey, the back can be coming from a disc up here. So we got to start with the neck because that's where the neck wants to be.
After you stretch and laser the muscle, do you do any work in the lumbar spine at all?
Right. Now I'm going to come back and I'm going to adjust her or put her on the blocks or do everything. That's what I'm saying. You got to take the muscle out first because you go and you adjust, well, what's going to happen? They're going to go out and do something like that and the muscle's going to wind back out and pull it out. This is the part when we say, how long does it last? If you can re-educate this and break these loops, you rechange their gait. This rechanges their whole pattern. This is where you can get the longest lasting potentiation is going to be doing these types of techniques.
Do you do any work at all on the psoas?
Yeah, the psoas, we could take her on the side. The table is a little higher. I would take her leg off and stretch it, but it's definitely the one to do. If she's on her back, you want to lie on your back for just a second. What I do is the same thing as I come, now turn on your side, face them. All right, I'm going to come up here. What I do is I have one laser just a little bit harder on you. It's easier with a table that comes up and down. The psoas runs through here. I stabilize her, right? And you can come in and laser. And this is it. If you have a table that goes up higher because she's so flexible, if I took her leg off the side of the table, it'd come down and touch the floor right now. You can feel it releasing pretty good.
Can you do that laser? You hold the right hand, laser with your left hand when you by yourself?
I can. I don't let them take any pictures though.
Does everybody
keep the
know?
door open.
Anybody not know what a cross crawl is? So you know how to do that?
There we go.
Everybody knows what the cross crawl is then?
Why don't you come on over? We'll leave you unbalanced there.
Yeah, just while she's there, let's just show you that real quick before you do that, just so they don't forget in case. A cross crawl means the way we should walk always. You go opposites, okay? So you just have her raise her left arm while she does her right leg, and then you do the opposite like that, and that reintegrates the brain back to normal. It's really better to have her follow with her eyes and look at the hand as it comes up there. Now, there's a way to figure out which side would be the best, but just routinely here, let's have her look at each side as she comes up there to make it simple. If you know how to check it out, you can be more specific. But then have them walk that way too, where they can walk like this, make it go out.
That would be the first thing I'd have them do. Right away, I'd have them go out and do that. Let's say that she'd hurt that and her straight leg raise was only to about 45 degrees. Well, her body has not, her brain has not had that potentiation through that over to 45 degrees. When the brain isn't stimulated, it starts to lose it, right? If you abuse it, you lose it. If you don't use it, you lose it as well. So this is reintegration back into the proprioception in the brain. How many times does it happen when someone has an injury and the brain is sort of put in a sling or something like that and the brain has forgotten about it? So this is reintegration. This is really what you're looking at. You can change someone's gait pattern dramatically, especially with athletes. I mean, you take athletes and you do these type of techniques like that, and no one else can do it. No one else can do it the way you can do it. And you can change someone's complete gait. I mean, I've treated people one time with shin splints and stuff like that. I treated runners who couldn't run, people that have clinics, that have running clinics that couldn't do it. I treat them one time, and they're back running like in 3 days. I mean, it's just, you just get wild. But then it gets a little bit more involved because now you have to do some, you reintegrate it and you come back and do some reflex loops and you reintegrate those, okay? I'm just going to do our psoas on this side because we did the other one. I'm going to turn face that way. So what you want to do is you want to come in and you want to stabilize her right here, okay? So I'm going to do it the opposite so you guys can see. Stabilize, bring the leg, so it's going to be outward. You're going to adduct, abduct, and rotate.
Question?
But you have someone that's like on dialysis, or you really need to get the psoas, and someone's really bad. I got one that I'm just treating now, and I do this every time for him, every time.
Tim Francis said not to do the cross crawl. There was one thing we said in the seminar.
if somebody's schizophrenic, you homolateral crawl them.
Okay, bring it up.
You don't find a lot of those in our normal everyday practice, though. But if you did, then they say you homolateral crawl a schizophrenic rather than cross crawl.
I'd still do some things because you're going to have to take it out, especially the adductors probably putting the strain onto it. Okay. So really, that's really how you're just going to break those things up. So now you really got to here. So if they had Achilles or if they had plantar fasciitis or something like that, now it's sort of like the shoulders, working the shoulders before you get in the neck. Then you start working into the feet and the calves more. But hers was pretty good, but I probably would have done more of the dorsiflexion of the foot while I'm doing the strain, counter strain. And then I'd come back and I would percuss down here and then open the plantar fasciitis, right? And reset the foot, Okay?
All right, one more. Okay, we have 10 minutes on the film to get rid of numbness in the leg. Come on up.
Numbness in the leg.
We have a real good team right here we've imported from China.
Check him. Check him right here. Sit down. Check. We'll check the disc. So we're in a routine.
Okay.
Arms up. So you're checking different levels. 5, 6, 6, 7, 7, 8. This is 8. Remember, 8. T1. Okay, all strong. All strong. Here we go. 5 goes a little bit. Not bad. You heard just like some clunking in the shoulder on the left. Wrist in.
He's a strong guy too.
It's okay. There it goes. There it goes. So where are we at now? What level are we at?
Both sides on
Yeah. What level are we at? Okay, come on, guys. Hasn't been that long. What level are we at?
7.
Yeah.
Okay, cupping. Cup tight.
I know we've been out of school for a week or two.
So we're getting T1 on the left as well.
Yeah. So these are the things. These are the things you guys should be thinking every time when you're doing a muscle test. Where does it integrate back into, right? Especially, as chiropractors. That's
It's got a lot of shoulder stuff too. But
okay. That's okay. We segmental. One we're doing low back on your back. Lay on your back. So we're going to tap him in. Boom, boom, boom. Away we go. Now we're going to mess around here. We're going to office visit. 10 minutes, 8 minutes and counting. I got 10 people waiting, but they're all on EEP, so they don't mind. It's in the water. It's California. It's in the water.
So he's doing the cervical disc again. You slide it along. Usually your anterior sternocleidomastoid, you rotate it through there and you tap it in. You're actually tapping the body. So it's an A to P rather than a P to A correction.
And this is really what we taught us in the neuro program, is that you look segmental, but usually it's something super segmental, something above it. So the foot drop on the right side could be right brain. It could be a consequence of cerebellar on the other side. It could be multiple things. So you don't just look segmentally. You could treat it segmentally all the time, keep adjusting it, but you never fix the thing or you get it to a certain quantum. On certain people, that's enough to bring them to a higher state and they're doing better. On other people, you're sort of scratching your head going, hey, well, where is it? Now you know. Got to check the neck first.
You see the high percentage of people we're finding cervical discs in? It's just scary if you miss it. It's like homocysteine. It's almost criminal. And when you try to set those without an adjuster, that's hard on you. You can still do it manually, but you roll them in, and a lot of us are winding up with problems in our neck from our years of bending over patients, and it really makes a big noise on the patient sometimes, so it's really nice to do it this way. Yes, sir.
Okay, what side is it more? So, right
What he's
side or left
saying
side?
is a lot of times you'll
Right side.
adjust in a respiration phase. And so you'll say breathe in, and then out, you'll adjust them or you'll adjust them in. It makes it a little bit smoother if you're doing it manually, but when you're doing this, it doesn't matter because this is so quick. Remember, speed overcomes resistance.
No problem.
So it takes less
We're gonna
force.
laser brain first. Okay. So, a lot of anterior thigh pain and other things. Let's just see where he is, straight leg raise. So, relax. Let me do the work. Relax. And this one feels pretty heavy. He's not quite as agile. Not quite as agile here. Let's just check. a lot more on this side, right? So when we talk about decrease in right brain, would that cause more flexion, inhibit extension? So what I'm going to have them do is I want to do 33 right here, left cerebellum. The left cerebellum fires right brain. Right brain, if it's at a higher state, should inhibit this flexion, right?
Say that
a lot
again, Doc,
easier on
because
the left.
That flows off so easy if you say it again. Left cerebellum does.
Left cerebellum potentiates right brain. All my environmental stimulus from my left side goes to my right brain. Everything from my right goes to my left, except for smell. That's the exception. It's direct. Still has to be interpreted through the thalamus. So if I stimulate left cerebellum, then I'm going to come back and I'm going to laser right brain. I'm going to hope to bring this to a higher state. To this straight leg raise will increase because I have inhibited the flexion, the hamstrings, calves, right? Flexors, inhibit the flexors, allowing for greater extension or a higher straight leg raise. Everyone with me?
One more time.
Okay. We're just going to see. I haven't even tested him, but I know that left cerebellum fires right brain. Right brain inhibits flexion or monitors. It's actually more of a monitor. Okay? Go ahead. Right brain. So, right brain? Yeah, so we do right brain. So, here.
The right brain monitors inhibits.
I'm going to go through it right now. So if I was going to move my right arm or hand, it's a consequence of my left brain, right? But this would be so powerful, I want to come up and hit myself in the head, that I have a regulatory from the right side, same side, okay? But this regulates it, regulates the flexion, right? So if I decrease this, I deregulate. Does that make it easier for you? Which allows for more flexion. So if the brain is decreased, basically you're going to get more flexion usually. And that's what we're finding out right now.
Now,
So I'm not touching his leg. I'm not doing anything to his leg. But I'm going to see if just by tensioning the brain that we can increase in the straight leg raise.
Because you're saying the right brain then inhibits flexion on the right.
Exactly.
is it 70% of the brain is inhibition? Is it 60 or 70?
70%.
So we think
70%.
about that. And the Parkinson's patients that you work with, by the time that they manifest Parkinsonians, I think they've already lost, what, 80%? 70 to 80%.
Yeah,
70%
70,
of
80%.
function. But so the brain is inhibiting 70% of the time. Its inhibition we're helping to correct so the body works properly.
Here's a good analogy. When you're a baby and you come in and you do a Babinski's, right? It's positive, right? As you get older, you come in, you shouldn't have that, right? Where'd the reflex go? It's inhibited. Why? Because the brain got to a higher state because you had more neurons and everything firing. When you get older, or if you have a brain upper motor neuron lesion, what happens? Inhibition goes away, so it comes back. Okay? So all those people that say, once you have that, you can never get those to change, that's a bunch of holy baloney. You bring the brain to a higher state, well, and back and inhibit them. So, I just want to show you different things. Okay? We were here, now we're here. Okay? Just the importance of looking suprasegmental. Now let's finish this up. Why don't you come up? So we're going to do the same thing. We didn't do anything
Just
else.
lasered the brain because the
Just
brain
lasered the brain.
is the control. Here's
Right.
the interesting thing too. What if you're not quite sure? Now, which did he say to do? That's when you self-test. You say, do you want this cerebellum? No, do you want this? Oh, okay. And then I go back and think about what it should have been. Okay, that's why it was because. So that's where muscle testing comes in, or self-testing. It'll tell you which side of the cerebellum wants it, and then you'll want to check, was it same side you want to do the upper? No, oops, opposite side in this particular case.
Okay.
Now, the more chronic it is, you might find the cerebellum and the brain on the same side. Where it's more of acute, it'll be cerebellar on the right, and then left brain on the opposite side, the cortex.
Now here's the cool thing. If you don't know how to muscle test, and you don't know how to do neurological balances, if you just take the laser and put it on GB21, it's going to do the same thing. Okay? Because it's right and left brain balance.
That's right here. Remember, because the corpus
Right.
callosum, the great white connoisseur, integrates you. That's why routinely when I treat, I take the laser and I just turn, I turn that thing. It has a guard on it, so if you accidentally turn it on, it wouldn't. It goes protected, so I turn it around where it's not into the guard because I've turned it on, and I stick it in the headpiece, and I do that. So if I'm by myself, I treat GB21 at every treatment. I don't do a patient without doing that. I'm constantly, I know I've automatically integrated the brain, I've upregulated and balanced right and left brain.
Once you hit this, sort of like water skiing, and you hit like a barrier, and all of a sudden you break through it, and the body just goes, oh my gosh. I mean, if he had his shoe off, we could see what color he painted his toenails. Now it's starting to begin to burn. Let's do the other side. Mm-hmm.
Hamstrings are really tight.
Really tight. Hamstrings are really tight.
Again, what if you didn't have a laser? Then use a percussor.
Yep.
You just go ahead and stretch it. If you're all by yourself, you put your shoulder into it one way and you percuss it with the other hand.
Exactly.
That's funny. This one
Now,
burns
does this take
Now
away
the left
from...
one's burning more than the right one, you said. So what's the burning? Is that the polarization of the nerve? Probably. Mostly it's sciatic, those type of things. It's the ischemic type of things that are happening there. Okay? Come on up. I want you to hold this.
from the heart.
What?
Could be from the heart.
Could be from the heart. Now,
we're going to get the leaky gut healing up with the proper nutrients to help it to heal and repair so he's not recirculating poisons that his nerves are having to interpret. So you have to do it all. And so we're doing segmental here to show you how we approach one area, but we've already done our homework. We've already know exactly which organs are under stress. And we have support going on nutritionally at the same time we do it structurally.
Okay, now he told us when I first got here, before he even got up, that when he comes to Arizona and he gets in the pool, he starts to get his heart, pumps those lymphatics and everything like that, his swelling goes down in his legs. So we already knew from his history a lot what was going on. So we knew from his history, we knew by looking at him, seeing the things that were happening. I mean, so a lot of it was already done for us. Then we just got to come in and get motion in the body. We've got to electrify him, get him on the good nutrition to really keep him going, get that heart electrical. And now I'm going to start going across. And then this one I go across, we usually come down more into the glute, depending where I feel it. So these are a little bit more labor intensive, but I mean, it's, once you can have assistants do this. You teach them how to do the TFL, piriformis protocol. You know? They can do all this. All this stuff. I like to jump in there because it's fun. You know, I get my exercise for the day. I gotta go to the gym. I've never seen a gym. Well, no comments.
The rest of them burn more.
So, and this one's burning more here on the left side. So let's just come back and check where he's at.
Now, do I see a surgery on that leg?
No, you just cut
I
it.
hit myself with a pressure washer about 2 weeks ago.
Okay, that's a cut. That's energy blocking there too. And
Right.
I all of a sudden
Not
I
a
felt
full
that.
surgery, yeah. I saw that too. So you can just see.
Plus I did cut to the vein there.
Yeah.
So we're lasering right into that area that he cut himself on.
Back into the adductors. Come in here, and this you can check finger modes. Is it structural? Is it chemical? Boy, chemical. I couldn't even put my finger together. So it's chemical. I come in, just lasering, come right through here. I can feel it more restricted right through there, and then locks in, and it just starts to go, just really unwinding. Ooh. Man, it's like hitting a wall, and then it just gives. Then it just gives. Now I feel like we're up there in that where he has that little bit something in the growing area. You feel that? Mm-hmm. Yeah, you can feel it, boy, just really locking in. There it goes again. Just talking about it, and we were talking about it. There it went. Whew. Yeah, that was a pretty good burn there. That was a pretty good burn. So what is this side? Is this what side structural, chemical, emotional, visceral? This side's visceral. So it's a wholly different component than the other side was. Stabilizing the ASIS on the opposite side.
This is different.
Yeah, this is visceral. Ooh, there it goes. How's this one burning in comparison? This one was burning more than the other two? The right one's on that one. So there you go. Not at that point. I could. You can be more specific. And if I reached a point like at the end, and I said, well, this is organ, Let's find out where the organ is. I probably wouldn't even laser here. I'd come right to the organ. And I'm picking up it was more like gallbladder. Gallbladder really where it was. Yeah, burns, it's okay. You're just depolarizing the nerve, right? You're just depolarizing. The nerve's being depolarized because the muscle contraction into it. What are you doing? Now you're bringing more, you're decreasing the metabolic load. You're bringing more oxygen. You're taking the muscle out of spasm. Right. So you're depolarizing it, right. So that's causing depolarization of it, which I'm not too worried about. You know, I'm not too worried about depolarizing the nerve at all because it needs to be broken up. Because once it's broken up, then it's not going to be depolarized all the time. But if it's contracted, it's getting compressed. Remember, when you compress a nerve, you have a nerve here. It's like this big, right? But there's different nerve fibers in the inside, right? You have large diameter fibers, which can travel a football field in 1 second, right? They're the ones that do the light touch and the vibration and everything like that. Then you have the smaller fibers, the unmyelinated fibers, which are the C fibers, which are tiny, unmyelinated. They travel a whole football field in 20 seconds. Now, the brain only knows frequencies. All it knows is the frequency in which it gets there, okay? The temporal lobe of the brain is the one that does all your auditory. But all it knows the difference between a tuba and a violin. It's not a tuba area of the brain, and it's not a violin area of the brain. It's only the frequency in which it gets there. The only thing the brain knows is the frequency at which the stimulation gets there. So that's why you rub yourself when you hurt yourself, because you stimulate the large diameter fibers, which they go 1 football field in 1 second, which inhibits the pain, which is going 1 football field in 20 seconds. Everyone with me? That's the pain gate theory, right? And that's the gate theory of pain. That's what you're doing. So that's what you're doing here. But when you compress something, what's compressed first? So if it's Doc, me, and Dr. Prisby together, right? And we're going to get compressed here. We're all together. Prisby and I are going to get squished to the dickens. He'll probably be all right as the walls come in because it's smaller diameter. So the larger diameters are the ones that get crushed first, right? But those are the ones that block the pain. So now you unblock those, you take those things off, now you're going to decrease the pain because you're inhibiting it through those pathways.
And how are you taking it off?
By releasing the muscle.
Laser and percussor. And the only two ways I know.
Guidance Neurophysiology 101, right? When a muscle is in contraction, it increases the metabolic demand, right? The brain and the spinal cord actually shunt blood to the area, right? Right? That causes increase in metabolic demand, which is the lactic acid buildup and cortisol, right? Both pain producing, right? You also have an ischemic reaction because the contraction causes ischemia to the blood vessels. So lack of oxygen also causes the pain, the nerve to be closer to the threshold, so it fires more spontaneously. So release the muscle spasm, release the metabolic need, decrease the ischemia, decrease the pain. I mean, that is just Guyton 101. I mean, that is the #1 thing in pain when you look at pain. And that's exactly what we did here.
In heart disease, they talk a lot about reperfusion injury.
Let's bring you up.
Yep.
Haven't read that.
Reperfusion after a heart attack. Ischemia causes this damage, and then
Right.
it's something that a lot of cardiologists right now about reperfusion injury. I don't know, I'm just going to start looking into it.
I'm not exactly what you're sure regarding to that. But that's what you're getting in the heart attack. You're getting ischemia, right? That's the same thing he's getting when you look at sciatic pain, right? The sciatic nerve is about 90% motor, 10% sensory. Sensory only travels to the brain, never travels away. So how can you ever have sciatic pain? Can't, right? So what happens? It has to be depolarized somewhere higher up in the system, right? That nerve has to be depolarized somewhere higher up. And that's usually oxygen.
Most of mine
Oxygen
has been
dependent.
ischemic pain,
Yeah, most of his stuff has been
particularly
ischemic.
after exercise.
After exercise.
Yeah.
So we know he's done a whole lot of things. Now he can start pumping those lymphatics, which we know helps his heart and his circulation, because when he gets in the pool, takes the pressure off the joints, he pumps the lymphatics, he doesn't get the swelling. Takes the load off the heart. So we take a load off the heart, he increases oxygenation, he pumps the lymphatics, he's going to be decreased pain. He's going to be better all the way around. Okay? So when you guys can start thinking about things and seeing what you're really doing and understanding the physiology, you're so much more zealous with what you're doing because you understand, man, this is what I'm doing when I'm doing that. Okay?
Very good.
All right.
All right.
Huh? No, Dr. Swarthout is going to make him write a book. He got more time than I do.
That's right. It needs to be written down because it's hard to get it down pat. One more person with low back or leg pain here just to demonstrate another thing. Why don't you come up just a second? Let's just demonstrate from a different perspective. If you didn't have that much understanding, but you did have an adjuster, you did have a percussor, what could you do? Tell us a little bit about you.
I've had kind of some low back pain for about 5 or 6 years.
Okay.
But the thing that's really killing me right now is I'm having some sharp calf pain, which just can't seem to go away.
You're pointing more lateral.
Okay, it's like right on that tipular head.
Okay.
So what nerve's
Especially
there?
when I go to the gym and I'm doing some calf presses, it just kills me.
What nerve's there? Posterior fibular head. Common peroneal. One of the easiest ones to get entrapped. Why? Because it's close to bone or close to tendon. So, I told you where the problem was. This is easy.
So what are we going to do? We're going to fix him. Okay? We do the 10-step protocol, of course. We want to know exactly everything about him. We want to be supporting him nutritionally, but let's go structurally. Even though it's a lower extremity,
Neck problems.
a lot of neck problems. Even though he's talking mainly, this is his primary area of pain, I'm going to start right here. I'm going to check him here. Well, I'm telling you, he has very limited range of motion, though, for a young guy. Boom, he's all locked up right here, big knot. Turn here. He has more range of motion to the right than he does to the left. Down lower, he's stuck. I still want to go ahead and check here. He's pretty decent there, not bad. This is worse on the left side, so I'm starting to see some left-sided stuff again. Left knee pin, left restriction here, turns easier where, locks up here. All this you weigh. Well, let's check right, left brain. Hold tight, don't let me go down. Count.
1, 2, 3, 4, 5, 6.
Hum. He doesn't show right or left brain weakness just by doing it that way. Count.
1, 2, 3.
Hum. Okay, so he does not show right or left brain. He's the first one we've checked that doesn't do that. What about cervical lesions? Turn here, hold tight, don't let me go. Or cranial lesion, breathe in, breath in through the nose. Breath in, hold. Pectoralis major clavicular bilaterally tested is strong. Exhale. Leaving the breath out, hold tight, don't let me go away. Okay, strong. Breathe in through the mouth only. Hold tight, don't let me go away. Okay, so he does not show the common either right or left brain pattern, or does he show inspiration assist or glabellar fault? So he's more intact than anybody we've tested up to a point that far, but he has a very specific problem here. He has a very specific problem in the neck with limited range of motion. Okay?
Yeah.
So I'm going to go right here. How do we, if we increase oxygenation, what do we help in the body? Everything. 3, 4, and 5 keeps the person alive. So if I have a fixation, subluxation here, I'm in trouble. The mirror image, I look and see which way he is. This shoulder's high, low, whatever it is. I go the opposite, plus a little bit more. I start down here, 7C, T1. I can go straight in, then I can just slide it up. I could have done a lot of other muscle testing or range of motions, but for ease in the office setting, this is just the way we do it. And because motion is more dynamic, I'm actually going to tap him in motion. Now I've really got him going here. Flexion, extension, rotation, even circumduction. Not only can you palpate, find the restrictions, but you can correct them in motion. Once I've done that, I come back, man, that feels better. I felt the range of motion come over here better. Really good. Now I come back, I just automatically know I've got better range of motion here, which means I have less neurological involvement here. I have better muscles firing more evenly. Okay, so we've done a lot of good stuff already, and we haven't even checked what he said the real problem was. What we've learned here real quickly, hold tight, don't let me go down. Could there be a cervical disc involvement? Nope. Doesn't show up. So let's go straight to the back. Let's start off face down for us, please. So we're checking there. Well, let's play like chiropractors here. Let's do a leg check. There's an interesting concept. Short right leg. Bend it. Just check several times. It looked like the right leg went longer, but then I do it several times. That's what Mortar says. Sometimes you've got to check it several times to get the real answer. It's really shorter on the right and stay short on the right. What could that mean? Well, it could be an upper cervical problem if you've ever followed Thompson's work, Jay Clay's. But let me just check something here. Well, let me do it through DAR so you can see. I'm going to muscle test through DAR. I'm just going to see. Remember, electricity travels to another person. I'm just going to contract the short leg side. I'm just going to push it down that way and check and see what happens. Look how weak it made DAR. She shouldn't touch him when I do that, should she? Because what that means is the whole sacrum has dropped down on that side and makes this a short leg. He said, yeah, but his pain's on the opposite side. What does that have to do with anything? You start chasing pain, you're in trouble. Let's look at what the body's telling us physiologically, and the pain will go away. So the short leg here, it means this is the long leg side. If you look at him up here, the whole pelvis is rotated. This whole cheek is up on this side. So you look at all of that, visualize. To correct this, if you have a drop piece, it's really nice. I don't know, you have to have Dr. Prismy show me how these work. Oh, there we go. There we go. This has a drop piece actually on it here. And the way you correct it is you contract the leg on the short leg side down while you push or hold the pelvis here, like that. So you contract it. That's lifting the sacrum back into place. You're using the, see how I'm doing it? I'm using the leg to flex while I hold the hip down. Then you'll come back and check. We no longer have a short leg. Usually it's a little bit longer. You can come back and check it then. Hold tight, and usually it'll be as strong as a rock. That is really a great low back, disc, pain in the leg. That really helps a great deal. Then once I've cleared that out, I then ask the question, is there a category 1? No. Is there a category 3? No. I don't pick it up. But then I still want to check that 5L to the left, S1, 4L to the right, just because that's such a common finding. And he has that as well. You mean have more than one problem? You can. Well, what if you lost your little head, or you can use any head to do that, but you can block here with your thumb. I'm holding S1 to the right, 4L to the right. I'm coming in 4th lumbar to the left. I just tap it. What if you didn't have an adjuster, but you had drop pieces? You just do it this way. You push 5L to the left, hold S1 here. Now sometimes there's actually a component where you might pull 5L to sacrum and check that, or push them together. Actually together. There's a specific situation where when you push them together, so I would push 4th lumbar superior to inferior at the same time I correct it. In other words, it would look like this. It has to do with the way the disc is injured or irritated, inflamed, and that'll take care of it. Well, what if you didn't have drop pieces but you have an adjuster? You do the same thing. You just find direction, and then you not only go from left to right, you go inferior at the same time. So what does that do for you? Balances the pelvis, balances the lumbar spine, takes the pressure off the nerves, takes the pressure off the disc. Well, is there anything else you could do with the adjuster for the low back if it's in trouble? Sure, sit up and face me this way. Wide fork. I can go ahead and put the wide fork on. And I could come over here and I could correct almost any part of the spine from here. I could come down 5, 4, 3L, just a general like P to A, or let's say that it's like a fixation. We find a fixation. You can do it this way. Back and forth. Say we have a subluxation here that we found by whatever, therapy localization, through palpation. I find there's a restriction there. I can take it here and I can tap it, both sitting up, or I can do it lying down. So there just isn't any part of the spine you can't correct with this very well. As you know from the previous classes we've taught, if you take 5, 4, 3L, spinal reflex, that has to do with the DNFT work back years ago. Van Rump found out if you would take a little rubber tip, double mallet here, and hit it with a little hammer, 5, 4, and 3L several times, that prostate problems would clear up on men, and that prolapsed organs would start to set back in place, even tipped uteruses would come back in place because of the 5, 4, 3L nerves coming off of there. So here's the way it would look. Take a breath in. Breathe out. In and out, rapid and shallow. So we're going to use the breathing as well. Okay. So now, back on your back. I feel comfortable. He's going to be better already. But I don't want to stop there. I've checked him strictly prone. What about supine? What's a couple of things that we've learned today? Raise it up, turn the toes in, hold out, and let me come down and just check any muscle you want to. That's the TFL right there. And just stretch it. See if there might be imbrication. Okay, doesn't show. Hold out tight. So we don't have to worry about imbrication. Could there be a category 2 with everything else we found? I checked, not that way. Yes, it says there's a category 2. When you check a category 2, it's literally a sacroiliac ligamentous interruption. So you block it, At that point, I want to check up here to see if he's torqued clear up into the shoulder. So if I check a muscle here and touch this shoulder underneath here, he's fine. When I touch this shoulder underneath here, he gets weak because his torque goes all the way up. No wonder he had neck pain as well as low back pain. So I'm going to block that at the same time. Now, if I had a laser, it's funny, it didn't show he needed any central brain thing, but I could check that. But I pick up he has a temporal lobe problem. I thought it was muscle testing. If I didn't know how to self-test, I could just say, how's your temporal lobe? I just touch it. It says, I have a problem with it. How's your left? It says, I don't have a problem with that. How's your left cerebellum? He says, I have a problem with that. How's your right one? So I know right now we have a temporal lobe on the right, a cerebellum on the left that wants stimulation. I could ask, how long? 1 minute there, 1, 2, 3 minutes on the left. So, yeah. What? Pardon? I muscle test like this where my fingers stick when I get the answer, but Dr. Amy does this.
No, I'm talking about when you're challenged, whether you need a laser here or using one finger.
Doesn't matter. I can do it from across the room. Okay. Right now, your right cerebellum needs it. Your corpus callosum needs it. Your belly button. No, I don't know about that. But you can just add. It doesn't matter. You're asking a question. You're communicating with the energy. I guess that didn't show. Maybe it shows. They show left temporal and right cerebellum. 1 minute there. Okay.
Excuse me one sec.
Absolutely, absolutely. Yeah, it just, there's all cranial techniques which you'll all be practicing this week. You'll be practicing the very specific technique.
Try to unwind them?
Yeah, and then what we're going to do there, now we're going to take the percussor, and we want to go right to the fibula head, right where he had the problem. Well, hey, this is a VIP. So while Dr. Amy is doing the left side, I'm going to come over and do the right side. Darlene's doing his brain. So I'm coming at the proximal fibula head there. He's in the proximal fibula head on that side. We're going to wind him at the same time. Do you have to go exactly the same place at the same time? I'm up on the distal femur. Doc's still down working the fascia all the way along because he finds the tibiofibular band is on fire the whole way there. So he's having to unwind the fascia all the way. Heck, I can help him out. I can drop over on this inside here and come across. I'm releasing the adductor, but I'm also helping to realign the femur head in relationship to the tibia and the fibula. I could come right on top of the patella, realign the patella itself because of that groove. It's very important that it works perfectly. He felt like on the, you hear what he said? Everybody hear him? He felt like he was getting a bump on that left tibia. Right, fascial inflammation, and it certainly is. So we're coming all the way down. Then we could jerk these shoes off. We could do the whole fascia of his feet. We could do his Achilles, as I mentioned. We could do the calcaneus, put it back into place. While he's on the symphysis right here, I can check that and unwind it. We could have been a little more specific into gait. We could have crossed one leg over and then the other one and checked it. It's a little harder to percuss this, so I chose not to do it. I can check that again his next visit when he comes in or maybe at the end. And I can come up here. Is there anything else needed? Yeah, his jaw's out. Check him here. Right's okay, but left in the clear is weak. Okay, bite down. That hides that one, brings this one out. But in the clear, I'm going to check it, so I'm going to have Darlene percuss that jaw. Is that legal? Is she a doctor? No, she's better than a doctor. Right? She knows exactly how to do it, so she's going to percuss right in the TMJ. Well, why don't you laser it? What if I didn't have a laser? You can do all of these superimposed laser percussor pretty much. It's just we like to integrate them together because one is kinesthetic, the other is light therapy. It's completely different. You're actually deeper in the fascia, of course, with the laser because you can go right to the bone. Same way with nutrition, it's from the inside out. So I'm going to work it with nutrition at the same time I do structure. If you need anything, I still have to go.
A little bit that left, a little bit that front.
Yeah, that foot's a little bit in trouble. Boy, his mom tied his shoelaces today. I guess we're going to have to untie him. Yeah. When he's a kid, his brothers used to get him. So we'll go ahead and do that. We'll get Got to go ahead and release that fascia there. Now you can really do this with the laser really good too. We do it where we can flex the feet and extend them and laser underneath here. Boy, it really relaxes the feet a great deal. Okay, let's see if he's into yin. Okay, with the block, he doesn't need the blocks anymore. He's into into weakness on the block, so I want to jerk those out. I don't want him on them if he doesn't need them. Okay, I don't pick up anything else anywhere until I get to the liver, and I feel a little congestion in the liver. But this was a leg problem. Anybody ever watch the meridians to find out where they go? So we're going to do the liver coming straight across here. Darlene's monitoring on the opposite side, unwinding the liver. How many meridians are there in the hand? Wow, we have lung meridian, right? Okay. Large intestine.
No, it's 10. Well, the voles. Okay,
Yeah.
I'm sorry, to the voles.
Yeah, we're just talking about. So same thing with the feet. 3 come up on the inside and 3 on the outside. And the meridian, the gallbladder meridian starts on the foot and ends at the eye. Right? Stomach meridian starts at the eye, ends on the foot. So anywhere along that road, you have a problem that can cause problems everywhere. Where it's going to or where it passes through. So we want to free it up all the way through there. Now, doing all this without talking, Darlene and I mean, we'd be bored after 10 minutes. We could have done every single bit of this. So if you have 10-minute visits, it's not a problem. Or with one person, could do it in 15 and doing everything that we've done here. Now we balance it out. He's helping with the torque. He adjusts the foot.
Put that toe down. Bring that toe down. Bring that toe down.
Actually adjusting the foot back into place. Now, what do we expect to have happen now? Dr. Amy's going to go ahead and he's going to use the adjuster now.
Just going to tap a couple in his foot here.
Why are you doing that in the foot?
Because I just feel where it's out, and I'm just going to check vectors and range of motion. You can self-test or whatever. He's got a drop tarsal here. So I'm just coming in, and I'm just going to feel it, and I'm going to tap it back in. Well, look at the reflex. Look at the reflex come back down. You want to see it? Watch. I mean, I give it a pretty good tap, but look, it goes all the way up the leg. Look at his leg. So that's too hyper, right? That reflex is too hyper. This works really great with people with hammer toes and things. Now I can take him into a flexion mode, a dorsiflexion, and I can really feel where it's locked now. And I'm going to drop a little bit below that. This works great. Look at the leg. Look at, and this isn't a hard tap. I don't have it loaded. Look at the leg. Look at the leg. Think that's too wound up? You think that's a pain loop, possibly? That integration is way too much, way too much. So I'm just going to do it till it fatigues. This might take a little while. If you had the laser, you could use the laser here as well.
Why don't we go ahead and reset the... What we're going to actually do, as you know, we check reflexes. What's what he's doing? He's checking that reflex. It's a hyper reflex. So what we're going to do is reset the reflex back to normal. How do you do that? With laser. Because laser is a modulator. If it's too high, it brings it back to normal. If it's too low, it brings it up. So we're modulating that reflex back to normal.
9. Yeah, you're really going to do a lot too above it and below it, though, to really do it. And I do a lot of brain on that side, too. The brain point, and I can come do the inhibitory, take it out. But, yeah, I got Rattay, who's going to be the second string quarterback for the San Francisco 49ers. He had a high ankle sprain, and they put him in a cast, and they said 4 to 6 weeks. We got him back in 2 weeks. And the first week, the orthopedics had him in the cast. I was yelling and screaming, but what can you do, you know? So finally, after a week, finally got him to take it off. But we were lasering in the cast, above and below. And really, Rattay? Rattay? Huh? Yeah. Well, his father's out here. He's actually from out here. You know, he's out from Arizona. But, you know, he came back. He had 6 touchdowns, 2 rushing, 410 yards and stuff like that. So he's
on the
number
back
2.
of his jersey, it says Amy,
Yeah.
Amy.
The crazy thing is we sent the laser out there, and then they wouldn't give it back because it works so great for the burns when they're playing on AstroTurf that they wanted to give it back. Oh, we got to have 1 more week because that AstroTurf's killing us up. You come and you laser the burns and stuff like that, they go right away. Stitches usually come out in 3 days. And the stitches, so they're getting some pretty phenomenal stuff.
You want to check it now?
Doing what? Not too often. A couple times a day, be plenty. Now, you start slow. You start slow with something to and work your way up. Look at it now. Still a little bit, but it's more global. It's not looped. They have like 1% of the loop. So now it's just more like you're getting a shunt you're getting a shunt in. So you just feel that the tone is different in it.
So what you want to do is check the reflexes everywhere. Check your patellar reflexes, and anytime that's hyper or hypo, you go right on the reflex itself and it resets it. And takes care of foot pains, elbow pains if it's up here. It just makes a massive difference.
Okay, and I'm going to adjust that posterior fibular head, and I'm going to come over the lateral malleolus. Okay, I'm going to put my thumb underneath there. Okay, one bone. I'm going to come behind it just like you guys do. Posterior fibular head. You're going to lock it underneath.
Hear it?
See that clunk?
Just lift it back into place so that whole fibula head had shifted. It had it locked up.
Okay, I found it was most restricted, but I took a lateral, but I came underneath the lateral malleolus, right? Because it's one bone, right? This is where it attaches to. So I have my thumb underneath it. I come behind the posterior fibular head and I lock it as a wedge, and it's a scoop. Wham. So I brought it back in, and I scooped it, but I was underneath there. And you could hear it. It is like clunk.
It'll just drop right into place.
Jumped it right back in.
It would look
One more
like
time.
this from the other side. Okay, you can even do it here, and you just thrust it like that, and it'll lift it right back in
He
place.
told us where it was. You could tell by the flexion. He tell you whether the pain. This is what happens when you get that, right? This is the common peroneal nerve gets entrapped behind posterior fibular head. One of the most common lower extremity entrapments. This is easy when they tell you that one. You laugh at money in the bank.
I've seen them where the knee was actually locked and they couldn't straighten it out. It's just like that. So that's, you do the same thing. You laser it, percuss it, come in there, it straightens right out.
Right. So. All right. All
Yeah,
right.
when you get tips on the floor, you keep shaking until it comes out paper, then you're done. There you go. See, we're doing better.
A little bit.
All right.
Okay.
Now, see, we keep it simple, right? Makes this stuff all real easy. So you can see with any problem, it is you want to look globally. You want to balance the brain, you want to balance the cervical spine, you want to balance the spine itself, and then go to the specific areas and do it. And you can just adjust the spine and expect N8 to do that for you, but that's probably been done a time or two and it didn't correct it. And we know it's a lot of material, so let's take it, let's practice it now. All right, what we're going to talk about now is frequency modulation, and we use that term when we think about frequency. You have to go back to Dr. Reif's work. Reif was a mad scientist many years ago who actually developed a microscope that was so sensitive he could see things that no one had seen before. He was the first person to see a virus and to document that. He saw the virus by taking a drop of blood, putting it under this microscope, and he actually saw it moving in there. And the thing that really amazed him is that he saw that the viruses were different sizes, shapes, and colors depending on which virus he was looking at. And that a virus and a bacteria and a rickettsia and parasites all look different, and they were all different sizes, shapes, and colors. Which means when they're different sizes, shapes, and colors, it means there are different frequencies. So he said, well, if I can see all this stuff and I'm drawing it from these people that are sick, why don't I document what I'm seeing and then find some way to weaken the bad guys I see in the blood? So he knew that when an opera singer could hit a certain octave, that she could shatter a chandelier. He said, well, that's pretty fascinating. Why don't I go ahead and take a frequency machine where I could say, turn it on, and then I would find different frequencies that were involved right here, and I could change those frequencies. So that's what he did. So you can see here, I can change that to 99.9, or I can change it by the flick here to 9,999, or I can change it to 99.99. Or I can go ahead and add whatever number I want to wherever and change them. So he would just take a machine like this, and he would keep changing the frequencies until literally he was able to explode the bad guys inside the blood. Well, this became so effective that he documented his work, and he had an MD who had corroborated his work, and they were literally, quote unquote, curing cancer patients and all kinds of things by finding the frequency of what was making them weak and balancing it out. Now, this went on to a point to where he became quite well known, and mysteriously the doctor killed himself, and about the same night some federal agency came in and smashed all of his equipment up. So actually what had happened is the doctor was killed, and they confiscated his records, and this became illegal to use because it's not nice to get people well without drug surgery. You know the story. Well, when the Rights to Practice Act went into effect here a few years ago, Orrin Hatch is the one that sponsored that, then it became legal, ethical, and moral to use a frequency modulator in balancing people out. But it's listed as experimental. So you can't bill an insurance company for it, but you can do it legally, ethically, and morally. But you can't say, I did frequency modulator to the patient, you owe me $975. You can't bill it to an insurance company. Now, this particular unit happens to be a TENS unit. It's called the professional TENS, an EMS TENS unit. So you can use it for muscle stimulation and bill for that. You just can't bill for frequency modulation when you're using it. So it becomes a dual-use instrument. So what he found out was that you could treat many, many things with this, and fortunately there has been a lot of research of his. In fact, all of it was hidden away, and when it became legal, all of a sudden it showed back up. So if you've read the book A Cure for All Cancers and A Cure for All Diseases by Hilda Clark, she has many of the frequencies in there. Each of the different units actually come with a manual, and it tells you the different frequencies that you can use. So let's just say you ran a hair analysis on somebody and they had high aluminum. Then you would just look at the figures in here, find out what the frequency is to release aluminum. You dial in the frequency and treat the patient, and it triggers the release of aluminum from the body, or mercury, or aluminum, or plutonium, or whatever. Or let's say that they not only have that, they have limes. Well, we could look in here, alphabetical, under this particular unit that comes with there, and it's all alphabetical. So let's see, HIJKL says right there, limes, and it gives the specific frequency or options of frequencies that you can use. So you would dial that frequency into here, and you would treat the patient with it. Like anything that's good, there's always other things that come along bad, and right now you have all kinds of people out there claiming to have different spin-offs of the Rife unit. So you have some you can buy, you can treat yourself at home with them, and they just cycle through a bunch of frequencies. So you hold it next to yourself and hope it hits the right frequency. They have some where it's channels, and they say, okay, we'll use this channel. Channel 5 is for limes, channel 12 is for liver toxicity, and it cycles through different frequencies. They have some now that cost about $7,000, $8,000, $9,000, $10,000, where you sit in front of them and the ray tubes glow and it treats you. And all that stuff is effective to a point, but it's not effective in a massive amount. So I'm afraid we're going to get some bad names. Other things that are happening is there's people doing open advertising that says, we cure cancer, we cure AIDS, we cure Lyme's with Rife technology. If that stuff keeps up, we'll probably lose the technology. That's why we're very careful to call this a frequency modulator. We're careful to call it a TENS unit, because we don't want to make claims like that. We don't want to make any kind of claims at all. You just want to know that there are certain frequencies that help the immune system to rebuild, certain frequencies that help the liver to detoxify, certain frequencies that help the body to get rid of heavy metals. So we know all those frequencies, we have them recorded, and what we're going to teach is a protocol for determining what the patient has, how you treat them, and to go from there. Question? Okay. All right. So let's just take a simple scenario here and show you how it would work. Well, let's say, has anybody had a hair analysis run so they know they have a certain metal? Okay, you had a hair analysis. What heavy metals do you have? Okay, so why don't you just look at that and see what shows up real quickly. Why don't you come on up, and we'll just show people how we would hook you up to that and how we would treat that. Yes?
I had a client who had a very large cyst in her pancreas and
Are you hearing? Come on up here. This is important. Well, you can get next to the mic. Let's get you on camera to do that. Darlene, she shows a significant aluminum, bismuth, cadmium, and tin. So let's check aluminum. Okay, why don't you come on up here and tell these fine people what you just said.
I had a client who was under medical care, so I didn't want to give her any herbs or any supplements. And so what I used was just the TENS machine.
What was the diagnosis?
She had a cyst in the pancreas that was very large, and she had a tumor in the liver. I treated her for many different things that came up on the muscle testing, and she had the measles virus also in the pancreas, so I treated her for that. And I did the frequency for all the different things that came up, and within the 2 months, it shrank to half the size with just using the frequencies on her.
And it would have been far better if you could have gone ahead and used the nutrition too, but you have to be careful sometimes. That's phenomenal. I mean, that's impossible, really, right? But this kind of stuff happens all the time. Okay, so we're letting Darlene just do a little bit of checking while I explain some things to you here. Okay, so we will show you that. So let's go over here while she's getting that. Why don't you have all your charts and everything ready to go over there? Okay. So let's just turn this thing on first, so you guys are all up to speed with what's happening here. So we have a machine over here on the far right. It says off on. Well, that's pretty good. It'll first come on and it will just blink because that's the timer. And you want it to blink there. As soon as it goes on, it'll give you your readings. If it came in and it was on 1 when it first turns on, then 1 is going to tell you it's only going to work for 1 minute, then that's going to shut off. If it was on 2 or 3 or whatever, so what I recommend you do, the way we do it anymore, is just keep bumping it from here till it goes back to 0 and just leave it on 0. That way the timer will be on as long until you shut it off. We had them put a timer on here because when we were first doing this, it would take 10 minutes to do some clearings, and so we didn't want to stay there and wait. We'd hook them up. We could go treat a patient and come back. But we've developed such dynamic ways of doing it, it doesn't take 10 minutes to clear anything anymore. Remember, we've also already done the 10-step protocol. We already have them on the drops to help the body release metals, etc., on the homeopathic metals. We have the right oils. So now I look up in here, and let me find something right here. It says right here, liver enlargement could be 727, 787. So let's just say I want to turn it to 787. So I turn this thing down to 0, that down to 0. I don't need that. But this one says 787. So there I am, 787. But it says point, so I can regulate this, and it's right there, 787. So I regulate the numbers by here. I can go up or down by the punch of a button. I regulate here how long, if I want it to interrupt. Right now I have this on interrupt because neurologically they have found if you leave somebody on a frequency that the nervous system starts to ignore it. So if you have it on interrupt and you turn it, say, where it interrupts just every 3 seconds, this will be going, and then every 3 seconds it will interrupt for as long as I have it set here. Right now I have it for only a 64th of a second, or I could have it interrupt for a second every 3 seconds, or could I have it interrupt 3 seconds for every 6 seconds. In other words, I have the wide option. Pretty routinely we leave it on just a very minor interrupt, a 64th of a second, about every 3 seconds. That's what we have found to work the best. That way the body fires, and then it kind of relaxes. All right? So let's turn this thing off now, and let's go over in action here with the patient that's ready to be treated on this. So let's talk about the preparation that we've done to get her ready here. Well, what did we do? We went ahead and we got a way to ground her to the machine. So we got pads, foot pads, right there, and we put a towel on there, and we dampened them. So now when we put her down there, then it has her connected to the machine. Almost always the left foot goes on red lead. So that means we're going to put positive through the left side of her body. Right? In your notes on the advanced, that all is listed, but it doesn't hurt to make a few notes here as you go along. So now that we're passing the energy, remember you're coming through the mic on the tape. So it's coming through her. What do we want to do that for? Because we want this current to literally go through her. This is why this is so much different than, say, a regular Rife machine. People are having them hold ray tubes in front of them or cycling through them. This is literally passing the current right through her whole body. So we found in her particular case that she had aluminum. Well, through the research, we have exactly what aluminum here, and it's 769. And then it's 0.01, so it's actually 7.69. How do we know that? Well, it was all calculated out. This was not one of Rife's frequencies. This was determined by a Dr. Max Collins, who developed this off the periodic chart, and it works extremely well. So we dialed in this 769, and then we, oops, you got her hooked up already, okay? Then we turn it down we want it to go not 769, not even 76.9, but I want it to literally be 7.69. Then, once I have that, then I turn it up until she feels it just barely. Tell me when you feel it. Okay, she now feels it. So I know she's monitoring that current coming through here. Affectionately, we say the way to do this is turn it up till they scream, back it off a notch. Okay? Or you can turn it up real slow. Now, once we have done that, we have her hooked up. We are passing that current through her body to trigger the release of aluminum. Then what we want to do kinesiologically is, let's just check a muscle here. Boy, that arm doesn't even straighten out, huh? I'm going to check through Darlene just to save her go power, okay? As you remember, electricity passes through from one person to another. So to tell if she's really going to be able to take this, I will shine this frequency in her eye. And you say, oh my gosh, laser makes people blind. This isn't a laser, it's an LED light, okay? It's a laser frequency LED light, and that doesn't bother you. Well, you see how it made her go weak when I shine it in her eyes? That means she's ready to be treated. That means, yes, her body recognizes aluminum, and you can treat it. Now, unless you've tried to get heavy metals out of people, you don't realize how hard it is to really get them to mobilize. If we change the number, I'm going to change it just, I'm going to turn it down so it doesn't electrocute her. Bounce. I'm going to change it to just 760. Her body says, what's the matter with you? I don't recognize 760. Crazy enough, let's go 763, 764. Nope. Let's see how close we have to get. 765. Nope. 766. Nope. 767. Nope. And we're talking about 1/100th of a point here, guys. Okay, doesn't even recognize it 768. And I tried to break Darlene's arm. There's 7.69. I mean, it's unbelievable. The body is that selective. It just blows your mind. So it says, okay, I recognize it. Now you can say, well, where is this aluminum? Well, we shine it right here in the forehead. It's not there. It's not in the central head. How about in the thyroid? Wow. Does she go weak? Parathyroids and thyroid. All three across there. How about sinuses? And there's a picture in your book that shows you exactly where they are. Then we come to how about thymus? Nope. How about lungs? Yep, it shows in the lungs. How about liver? Whoa. How about kidneys? Okay. How about hormones? Everywhere. So anytime you find the liver, you always want to go opposite kidney if it'll show up. If you find spleen, you want to go opposite kidney. We only have 4 sets of pads, and so we only can do 4 areas. Well, she showed it so bad in the thyroid, parathyroid area, we're going to put a pad here and a pad here. Because now we don't only want to treat her where we pass it through the feet, we want to really pass it through her entire body. So what we can do is take leads. This is a TENS unit. I can pass very specific TENS frequency to her. Where are they? Do you come down there? Okay. Oh, okay. So then we take these units that we have connected and we attach them to each one of the pads that goes on the body. So remember, we found thyroid, parathyroid. We found lungs, so it's a little bit tricky to get under there with this kind of shirt. Yeah, I guess we better go liver. We'll go liver, and then opposite kidney. And then I also ask, while I have this, I want to know which way do I go, positive, negative, negative to positive. And I say, well, we put it on the liver, does it take black or red? It says black. And I have to muscle test to know that. You need to know which way to do the current. If you say right here, okay, hold tight, let me go down, red, black. So it says black. You have all the others hooked up? You hook those up. You forgot our system there. So Darlene will put the pads on while I hook these up. We'll get a system back. We don't do it this way anymore, so we're a little rusty on this. Forgive us. We've gone to the new laser frequency. It's so much faster. And then we found hormone levels too. So we're going to come down just to the lateral side of the umbilicus and above it, and we're going to put pads on there. Again, I have to ask, negative or positive? Question, doctor.
The hormone points for this different from the hormone points.
They do, because you don't want to put one of these pads on the nose. Okay? We could, but if there's bill current, I wouldn't. If they haven't paid their bill, I'd put it on their nose. You know, they'll pay up right away. Because this is electricity going through here. Is that all 4 of them, or are we still like one? Spleen, pancreas, okay. I mean, she showed so many, you can only do 4. But boy, all this whole area through here. Now this one is red. on the spleen, and on the kidney it's black. Okay, she's wired for bear, isn't she? Is she not? I mean, we identified, yes, she has aluminum. We know where she has aluminum. We know the frequency to get rid of it. This has never been done for her in the age of man. And you can take people that have had 30 chelations, 50 chelations, and they're referring to us now because they've got the lead out, but everything else is still there, and these people are getting sicker. One guy with Alzheimer's, they just referred to us last week. So, pardon? She's had 30 chelations, but she still has all these metals. It doesn't get them out. So now what we're going to do is do that again. We're going to turn it up, remember, till she screams, and then back it off a notch, real slowly, to the point to where she can tolerate it, but you always have to have a light to really work, if at all possible. Okay, so, all right. So then the next thing we're going to do is Darlene's going to shine that right in her eye. We try to get her as comfortable as we can. And we're going to have her talk to us, all right? Tell us what colors you see. She said, well, you idiot, I see red. What's the matter with you? How am I going to see anything but red? Oh, now she sees orange from red. How's the eye seeing orange when it's red? Now what?
It's a red dot and orange ring.
Okay, now what? It'll change. It'll continue to process. Yes?
The colors she sees correlate with the colors on the chakras.
You got it. Exactly. See, it takes a student to figure that out. What she will see is the frequencies. She'll process right through the chakras as it clears. She'll start off with red. She's seeing orange. Where are you now? Has it changed from red-orange?
No, it's still red-orange.
Okay, she's moving really slow. Okay. It's locked already? Okay, so she's not going past orange. That's not good because she's not getting above that chakra for healing. Oh, she got all the way to purple. Right up to purple. She just finally processed all the way through the chakras. Now, by the time we get to this place on patients, what have we done already? The entire 10-step protocol. We have them on the nutrition. We've percussed them. Go ahead and turn your jack on now. Okay. Okay, so now the second eye, is it starting to show colors yet? Okay, she's very resistant. So if this happens and I can't get her to there, you keep... It finally went to purple, but you're seeing red-orange and it goes from red-orange right to purple? Okay, did you see any other colors between there? Okay, it doesn't matter whether they do or not. If they go to any part of purple anywhere, then they made it all the way through. What if they get stuck on a frequency and they don't get past there? Then a lot of times we'll go ahead, once we're checking to find out how long the body can take it. All right? The other thing that you can do while you're doing this, you're checking through here. Whoops, that arm is so bad, I'll check through Darlene again. You're checking through here, and then if their thymus therapy localizes, and all of a sudden it blows weak, okay, or your muscle testing, it locks up, then you know the immune system can't take any more at that time, even if it didn't go all the way to purple. So you know you stop right there. And if you have the glasses, you find out where it was they stuck. Let's say they stuck it green, then you go ahead and put that color on or the next color up to see if you can jump start them out of there. Then you go ahead and do other treatment to them. All right? Then what Darlene is now doing is taking the light and she's going to auricular therapy points to help facilitate the body to get rid of this. We used to go to all the other organs that we found trouble into besides where the pads were, but remember the pads are working right now. But we found by taking this light and just going on the whole ear, even if you don't know auricular therapy, you just go ahead and muscle test, self-test, or just go over the whole darn thing real slow, and you'll go over the whole area.
Both ears, Dr. You auricular therapy on both ears?
Yes, on both ears, on both sides, because you want to signal both sides of the body. Now, according to the auricular therapist, they say that the auricular therapy is the tie-in between the psyche to the soma. So it's pretty powerful. It major emotional things. Now, while they're on here, Darlene and I do everything else too. This is when we'll go ahead and we'll check colors to see if there's an area of emotion she wants to work on. Boy, she shows blue big time. Even though she was able to get to purple, there's some emotional areas. I'm going to ask her to open her eyes just a minute and to look through the blue glasses. Now you can close them in. Just takes a second looking through. The eye registers the color. Now she can rest her eyes if she wants to. Now the eyes, when you... Well, yes, because she's kind of tired. She actually has a medical diagnosis of Lyme's disease. So it's exhausting for her to get here today to take the class and to be treated. So she's there. and she's resting. She's processing emotionally, even if her eyes are closed. And when you look at that, I hope Dr. Amy brought his slide that he'll show us this week, but he actually has an overlay that we made. When you put it up on the overhead, you can see how the eyes tie into that part of the brain and how the ears tie into that part of the brain. And so when you're treating with vision or auditory, you're actually reprogramming the brain. That's why color is so powerful. Remember, the more the senses you can tie into a treatment, the more healing takes place. So if you can get visual stimulation, auditory stimulation, it's not just stimulation, it's like balancing, it's modulation, it's healing. So is that clear?
Yeah, it's clear on that.
Okay, so she cleared on that. It isn't imperative we jerk the glasses off right now. She's still processing on that. Then what's the next thing you want to treat? Well, you go to the book and you ask. So you have to have some way of asking. If you don't know how to test at all, you need to repent and learn how, okay? In other words, if you can't muscle test, you can't self-test, you're not psychic, then you need to develop a way to be able to tell. Or you can just go ahead and you saw her test. She had aluminum, she had sulfur, so we could check sulfur because she had high sulfur on her test. So you have, okay? So we could just check the chart for sulfur, look it up, turn it on, shine it in the eyes, see if it made her go weak. Well, we do know how to self-test, and she showed parasites. What frequency?
She shows 7,000. There's 3 or 4 that she shows.
Okay, there's 3 or 4 that showed up. 7,000 is one of them. So what do? We turn the unit back on. Okay, it's always going to flash there for just a second because it's checking to see if you want to have a timer. Then we go ahead here and we turn it on to 7,000. That is correct. I try not to do 2 metals back to back unless the body makes me do it. Sometimes it'll choose that as a priority. I'm going to tell you yes for now. Yeah, usually you want to check, go to that metal first. When people come in and we do a Serter, one of the first things we check them all the time for is metal. And it's rare somebody will come in on a visit when you're doing this deep work, they aren't ready to help get rid of more metals. I mean, absolutely rare. The body wants to get rid of this stuff. So now we have this frequency in, and we flipped it over. This is not 0.1 or 0.01, this is a pure 7,000. So she's dialed on 7,000. We then go ahead and turn it up slowly until she feels it again with the light. Now on the 7,000 frequency, we then muscle test again.
Really don't feel it, I don't.
Okay. If we can get a little bit more, that's fine. Sometimes it'll show up on the sinuses or up here on the TMJ, and that's when they usually just feel metal coming pouring out of their parotids. Bersendahl said years ago that he gives parotid tissue because it helps the parotids help get rid of heavy metals. So that means they're trying to suck them in there. Well, the nutrient that he used, I think, had a couple of milligrams of parotid. If you look at DSF, it has 80 milligrams per tablet of parotid for that very reason, to just suck out the toxins before they ever get down. The parotids tag or encode the body, so when you put something in your mouth, it tells you whether it's good or bad for you. Okay, so we're going to check her again. Normally we check her muscles, but we're going to go right into the eyes. Wow, big time weak. How about thyroid? You remember what she said? She's on thyroid medication. She also has exophthalmos of her eyes because there's so much pressure. When there's pressure on the thyroid, she has all this poison inside of there. So if we can, we're going to see if we can leave the pads exactly where they are. If not, it might change. We have to pull one pad off and reapply it. But right now, it chooses to do all of that. So where do we go? Right back to the eye again. And we're going to do there until we process through these colors. Of course, you have the glasses off because if you shine the laser in there through the glasses, it's not the same frequency. You've altered it. Well, while she's doing this, if there's 2 of you, what I want to do is go ahead and get a percussor going here because I know I need to dump this junk from her system or help her do it. She has to do it. So I'm going to come right down to the cystic duct. And you remember the cystic duct drains the gallbladder down into the small intestine where it meets up with the pancreatic secretions. So I'm going to come just underneath the rib cage right here. I'm going to come right here, and I'm going to...
It's supposed to go, we want it to go to purple, but if you stayed on red, we have it blocked there.
So is it staying red?
Stay red on the right side.
It's a part of her problem. She's not excreting things properly. So I'm coming down here on the cystic duct, helping it out.
Can you change?
Great. Then I'm coming right over to the liver to release it.
She's sticking on reds.
Okay. So I just release the liver. I want to do a shock release. You know from your previous training to do shock, you stand on the left side of a lady, the right side of a man, and I'm going to come right in with the percussor in my fingers. I'm also going to release it because this will release emotions. And I just show you here how I know, but I see the difference here. Let's just show you something here. We're dealing right now passing this current through. So she's into weakness. Just touch her emotional centers, darn. Okay? Okay? The body's not even ready to get rid of the emotions, and yet it's a major factor. So let's see what this does, putting the red glasses on her. Okay. Now that locks her in. So she's willing to treat emotions through color, but now she's not ready to treat them, process them otherwise. Question?
So, because you're on a parasite, done with the metal, we're on parasite, so it's a whole other emotion now, so we're going with a different color.
Absolutely. It can be a different color, different emotions, all kinds of stuff can be different. That's right. Every frequency seems to carry with it its own baggage. So now she has the red glasses on because that's what it showed. It wouldn't go past red, so we're going to check red or orange. And I picked that she's passing through red pretty good. We're getting up to orange here now a little bit. But I might want to really treat her deeper emotionally with the glasses. So where she chose red glasses, all I have to do is to read in what red means. Well, red means right here, according to this, it is the base of the spine, the adrenal. See how Dar's tapping her head or her heart? You tap either one of those two places, and it taps the information in there so we can release it. So red is the base of the spine, the adrenals, the kidneys, the bladder, the colon, the spine, spinal column, and legs. Red has to do with the emotions of I have, I have. Red is the balance in relationship to the physical, survival, sensory, stable, secure, self-preservation, instinctual, being grounded, being primal, spontaneous, active, or courageous. So we tap all that in. And then it says right underneath there, the complementary color is green. Green. She also gets weak when you say the word green, so you know the green emotions are in trouble too. So you come up here and you read these. And Darlene taps them into the head or to the heart. It's stacking this information in like we've been talking this weekend. You want to stack the information in. And green is heart, thymus, circulation system, arms, and hands. It has to do with I love, I love. Green is the balance of unconditional love, forgiveness, compassion, generosity, openness, contentment, sincerity, understanding, acceptance, harmony, nurturing, assertive, and healing loss. Green has to do with healing loss. Well, that's pretty powerful considering what she's going through here. Well, once we have tapped those in, now what do we do with them? Well, we want to find out, is there an I position that locks the memory of all this trauma in there? And we want to clear it. Because remember, our goal is to release scar tissue no matter where it is. So there will be an I position that will release the scar tissue, so you have to muscle test and ask. So if I was checking her muscles, like I say here, is it this way, is it this way? So it says it's this way. I'm going to ask you to open your eyes. Follow, follow, follow. So you have her literally follow with her eyes the I position that cleared it, and that will completely erase all those emotions that are in there and allow her to process through the upper chakras. The eyes are very connected to